when I say it's an okay number because it's not going up. And it's an okay number because at the moment we're able to operate pretty much on everybody in the time frame that we think is medically indicated. So we haven't had...
So it's not really a wait list then, it's not like it's a broad term, is it?
It's not kids who need surgery now who are still waiting. Everybody who gets put on the list gets prioritised, and the priorities are in hospital if they're in hospital and need to be operated before they go home. 2 to 4 weeks, 1 to 2 months, and then routine, which is within 4 months. A lot of the routine stuff, from a medical perspective, could wait longer than 4 months, to be honest. But the ministry says that it needs to be done within 4 months, and that's usually a good thing. I mean, families don't want to be put on a waiting list for some period of time. It could be 4 months or could be 12 months.
Right.
But yeah, that the size of the list at the moment allows most things to be done in a way that fits in with when they need to be done. There are times when that's not necessarily absolutely true, like around Christmas and New Year. Every year things sort of get into a bit of a crunch, coming up through end of November, December, because elective surgery shuts down essentially over Christmas, New Year through to about the 3rd week of January, really. Yeah. But I take your point, perhaps it should be less. I mean, the wait list has kind of run around between 30 and 40 most of the time, so 50 is slightly higher than it has been in the past, but still within manageable levels, and it's not going up.
Do you expect the new surgeon to help alleviate some of that?
Yeah, so let's talk about the surgeon. Thanks, Melanie. Yeah, so we, at the moment, we have Kirsten. We have Naveen Davidson, who was a trainee with us, who's staying on for an extra 6 months, who can operate independently, but needs some level of supervision within the hospital. And we have a new surgeon starting in December, actually came for a month in August. He was appointed, I better get my facts right here, I'm on camera. He was appointed, I want to say a year ago, but it may have been at least a year ago. And the deal was that he had contracted to do a year in Melbourne, and in the interests of good karma with the Australians, we agreed that that would be a good thing for him to do. So I think people have rightly brought up, look, Liz Rumble left ages ago, why has it taken so long? And the reason is that we think this guy's going to be terrific. He's a junior surgeon, we think he's going to be absolutely fantastic. And we sort of made a decision to suck it and wait. And then of course, while we were doing that, John, our other surgeon, got an offer in San Diego that he couldn't refuse for a variety of reasons. One is that he's American and wanted to go back to the States after being here for 10 years. And it sort of happened at the wrong time, to be honest, for us. This is not, when we talked about all these areas where we have 1 or 2 people and the kind of vulnerability that goes along with it, this is not a New Zealand unique situation. Brisbane have had a single surgeon on and off for 7 years. They've got a second surgeon 12 months ago, but prior to that, Nelson Afonso, their surgeon, was there by himself for 18 months. It's not a unique situation. There's a single surgeon in Perth. In Perth, they do ship a lot of their complex stuff to Melbourne, so that's less of an issue. And in Brisbane, they dealt with that by getting a helping hand from surgeons in Sydney who'd come over to Brisbane and let Nelson have a weekend off, just the same as we've had people from Melbourne come over here and let Kirsten have the odd week off. She was been away last Thursday, I think, to yesterday afternoon. So and we had a surgeon from Melbourne covering, and he's going to be doing that for a few more times over the year. So these arrangements, they're not what you like, but I'm afraid it's sort of the way it is. So we're expecting to have AJ Ainga start in December. In fact, not expecting, he is starting in December. He's looking at houses. And
I talked to him in the weekend when I was in Melbourne, and I got his permission to put it up on our Facebook page. It went up this afternoon that he was coming and starting in December. And as an absolute layperson who knows nothing, he's lovely. He's not only good looking, but that's neither here nor there. He's such a personal person, and to me that's much more important, because sometimes it's quite hard to talk to people when you're in such a stressed situation, and he certainly doesn't come across like that at all. And he's really smart too.
Yeah, so they've had similar situations in Brisbane. Interestingly, they're not looking for a third surgeon in Brisbane. You've got two young guys, and they don't want anybody else. They want to have a good caseload, which is actually really important, which is probably something that's worth talking about. We've just been interviewing for the third surgeon spot, and we've got 3 top candidates who are all very good. And I'm hoping that we can get an offer out in the next 3 or 4 weeks, and potentially have somebody start sometime in the new year. But caseload is, that's the other issue that is kind of not straightforward. Why don't you have 5 surgeons? That would solve the problem. Emma wouldn't like that because that'd be 5 salaries, but that's by the by. And the reason is that you kind of need a good caseload, especially for young surgeons. They really need to be doing a lot. It's not just that they get grumpy when they're not operating, which they do, but they really need that constant experience, constant exposure. So most young people will be looking for 150 to 200 cases a year. The numbers up there, we've got sort of 350 to 400 cases, so it kind of makes it difficult to entertain 3 people. Yeah.
Is that why there's no private cardiac for kids services in New Zealand, because there's just not enough demand for that, or?
Yeah, I think there's no funding for it. That's the problem. Insurance companies won't cover it. And there used to be private, Barrett Boys used to do a few cases up at the Mercy. A lot of them came from out of the country, from Indonesia actually, I think, years ago. But yeah, insurance companies won't cover congenital abnormalities by and large. A few policies will, but most won't. And I think it's a good thing that we don't, because what we do know is that case volume drives results. It's been really nicely shown in studies around the world. In Sweden they had 4 or 5 units. They closed 2 or 3 of them, so they now just have 2. And their outcomes data just went like that, improved very dramatically. So concentrating stuff is really important. Having teams all around the city is kind of not such a good idea. There's 2 edges of this. You get complacent when you're the only place in the country. So a bit of competition might kick people on the backside, and sometimes I wonder about that. But the other side of it is that concentrating the volume has been shown to be associated with much better results. Yeah, it's similar. Queensland is similar to us. Yeah, and so but the thing that we don't have, that they don't have, that we have, is rheumatic heart disease. And they don't do the adults. The adults who are born with heart disease get done at Prince Charles. They get done by a different set of surgeons. So our volumes, our numbers are slightly higher than theirs, But if you look at the numbers of kids that we operate on compared to them, we're very, very similar.
What are your wait list numbers?
I couldn't tell you. Yeah.
And the third surgeon who you're interviewing, how experienced is he or she?
Well, as I said, there are 3 candidates
Yeah.
for that job.
Are they more experienced?
There's reasonably senior surgeons, or a variety.
They're not
I can't
another
say.
junior, is what you...
Yes.
Oh, yeah, no,
Yeah.
no.
Tom,
I can't comment much more on that.
I wondered if it would be interesting for people to hear the level of interest in that role. You know, I was surprised just how great the interest was in working at Starship. Yeah,
Yeah.
and just a little bit of the process we went through around that.
Yeah, I don't know how many candidates we had in
Wasn't
total.
it
I
20
think it
odd?
was, I was going to say
Close to
18 or
30,
something like
It
that,
was really
yeah.
high.
I mean, a bunch of them were
Mm.
people that, you know, probably didn't qualify for the job and were pretty easily triaged out. You know, it was actually really quite gratifying. I mean, I think we are. I'm being filmed here, though, so I have to be careful. But you know, we are regarded as being one of the best units in Australia and New Zealand. Certainly, you know, Melbourne kind of has lots more money from the Murdoch Research Institute and stuff. But other than that, you know, we're certainly highly regarded in the region and around in a broader sense as well. You know, so we do, as I said, we've got 3 very good candidates, leading candidates for this position. So it's looking quite good. I was going to say something more about surgical volumes, and yeah. So the issue with this is that, you know, with 350, 400 cases, it's not quite enough for 3 surgeons, and it's marginally a bit too much for 2 surgeons. So that's always, you know, that's the dilemma, is keeping people entertained. Sounds terrible to say it that way, but, you know, giving people who really want to work enough work to do, to make them happy in their job. And so that is sort of the dilemma with a unit our size. And there's ways of working around that. We have 2 surgeons working together for complex cases. That's one way to deal with it.
And a small number of non-resident.
And the other way, yeah,
patients.
thanks Emma, is you know, is to bring in non-resident patients from time to time as well. Yeah. So that's the rationale for that sort of work that we do. Is not just helping people in the Pacific, which is obviously something that we kind of should do, but also that, you know, we need to keep those surgical numbers up so that we can make our 3 surgeons happy and not be down to 2, which is just a bit vulnerable for everyone to sleep well at night. Yeah.
You've obviously managed that in the past, though, because we had 3 surgeons for quite a long time.
We did have 3 surgeons, yeah, and so the way that we did that was to increase the volumes with non-resident patients and things. Yeah. You know, it's doable, and Kirsten's not here, so I can't speak for her. But, you know, she's reached a stage of her career where I think, you know, she's going to be happy to step back a bit, do a bit more teaching and a little bit less first-person operating. Yeah.
Are there other issues, not just surgeons, but also the anaesthetist and all of that? You want to find enough again, so I understand it?
Yeah, you know, there is some time to time, and that's where, you know, the bottlenecks just tend to be transferred. I mean, we had a bunch of cancellations about 2 years ago because we didn't have enough perfusionists. And the reasons for that were partly that a few people decided to go back to the UK, and partly because the scope of work for perfusionists increased. We're doing more liver transplants, and I didn't know that you needed cardiac perfusion for liver transplants, but you do. I found that out one morning. And so, you know, that's scope of work changes, and the numbers of people vary. The difficult time for us, for ICU nurses, tends to be about March, April, because that's when all the young ones disappear to the Northern Hemisphere for their overseas experience. So, you know, we always tend to have a bit of a staff shortage at that time.